So you don't consult when you're designing solutions, and you don't consult when you're taking away your benevolence. You just wake up one day. Nobody was asked, is this a good thing? Does it help? Is it helpful? So it's that whole system where we've put ourselves in a position that people can create solutions without asking us, and they can take away those solutions without asking us. So nobody asked the Africans whether this was good, whether it was helpful. Somebody sat down and in 1 month decided that a program here, which had existed for, I don't know, 40 years, is not useful. And they just scrapped it just like that. And then we find ourselves in this situation.
Welcome to Unpopular Opinion. Today, we are honored to have Dr. Catherine. She is the Executive Director for African Population Health and Research Center. We are going to be discussing Africa's health and research, navigating the impact of USAID funding cuts. Dr. Catherine, it is an absolute honor for us to have you on today's edition of Unpopular Opinion. For a start, can you tell us about yourself? Who is Dr. Catherine, and what inspired you to continue doing the work you are doing for the African continent?
Thanks, Muhammad, for having me on this podcast. It's interesting, unpopular opinion. I think I have very many unpopular opinions. So I think this is the right place to be to share my, I think sometimes crazy perspectives about the continent. So as you've said, I'm Catherine Choktunji. I am Ugandan, but for almost the last 20 years, 19 years, I've been based in Kenya, where I lead the African Population and Health Research Center. And I think in short, it's APHRC. And APHRC, I think, is maybe the perfect place for me to be as an African at this stage of my life, in my career. I've been there for a very long time, and it's for that reason that I've been there, because it allows me the platform to be the African person I want to be. And so going back to my background, as I said, I'm Ugandan. I trained as a doctor many years ago. I worked for a very short time and was disillusioned by the whole healthcare system in Uganda. And then I thought that, okay, since the healthcare system is focused on treating diseases, I should go and do public health, which is more about what can you do to stop the diseases and maybe to create health instead of waiting to treat diseases. So I brushed into public health and I did a master's in community health and health management. And then I got a PhD in epidemiology, which is the study of the distribution of diseases and their causes and patterns. And then the application of that knowledge of disease patterns to try to solve problems. And as you can see, this is just was right up my alley of what I wanted to do. And so after that, I started the research career at APHRC and very rapidly grew into a leadership position. And about 7 years ago, I took over the leadership of APHRC. So in brief, that's who I am. I have a whole YouTube series of about 10 hours talking about my life. So I can't summarize it in this segment, but I think that's okay.
Thank you very much for that introduction. I want us to go straight to our discussion. That is, the USAID funding cuts have sent a shockwave throughout the African continent, almost in all sectors of the African continent. But one of the key areas that I want us to look at is the health sector. And South Africa, it is estimated that over 500,000 people might be unalive or will be killed as a result of this funding cut. Uh, what can you say about that, and what does that represent for the broader African context? Also, the Brookings Institute have also warned us that the funding cut will result into global health crisis. So, what are the most pressing challenges for the African continent, and what do you think we can do as an African to be able to mitigate this impact?
So the USAID funding cuts, somebody described them as geopolitical vandalism. I think I would call it geopolitical. It's like a geopolitical hurricane that has swept through the global health sector. And to be honest, it's a mixed bag. In the short term, it's terrible, it's catastrophic, it's devastating. In the medium term, in the longer term, we have to wait and see what happens. And so we've been living in a system whereby a lot of African countries are dependent on this kind of funding, where African politicians have outsourced healthcare and other sectors to, the benevolence, of people many, many thousands of miles away. And it has created a system where we almost live as if those other benevolent people did not exist, then we wouldn't. And I think we've been conditioned to believe that. And so our political class is very happy to outsource our problems to other people and to constantly adopt a posture of helplessness. We are so poor, our people are very sick, we have so many problems, help us. And so this posture of helplessness has created this kind of symbiotic relationship between ourselves and the powers that be, where we feel beholden to them. And then, of course, they benefit from this benevolence that they give us in other ways. So they use this development aid as a lever. They can, panobit us into line and to take certain positions that benefit their own geopolitical interests. So that is the thing. Like, there's this huge infrastructure that has been dependent on the benevolence of rich countries for many, many years. And it is so entrenched and established that so waking up one day and a very powerful person in the world at the stroke of a pen, literally creating chaos across the world. The chaos is unprecedented, unbelievable. There's disbelief in the sector. And those estimates about people are going to die, people are going to, maybe become sicker than they are, they're not they're not lies, they are true. But that's the problem. How do you, as a continent, I've said this before, we have almost 1.4 billion people. How do you as a continent experience this level of chaos because somebody put a signature on a document? How did we get here? That we are so entangled in this whole system, and at the stroke of a pen, chaos ensues on the continent. Even the relatively well-off countries like South Africa, as you've said, that is chaos. How did we get here? I think that's the question you should ask. So, no doubt, in the meantime, in the short term, the chaos has started. I think it's at two levels. There are thousands and thousands of Africans who have lost jobs overnight. It's not something which was planned. You wake up one day, you have a job. The next time you're being told, oh, you can't come to work tomorrow. And then 1 month later, actually, don't come at all. This is the end. So this is chaos on one level. And of course, from a social perspective, these are people who have dependents, they have school fees, they have kids, they have rent, they have loans, they have all these responsibilities. And all of a sudden, you just pull the rug, no warning, nothing. And for me, that's one of the things which is quite disturbing, that the way the development sector has been set up is that we don't have too much choice in what happens. So the US government will sit down and say, yeah, we have a priority and we are allocating this amount of money to this priority without asking necessarily whether that is a priority for the country that this aid is being given to. And then they say they put up a call. We have $500,000 for HIV in Kenya. Okay, so these big NGOs based in the US apply for this money, and then they come and implement activities in Kenya. So the consultation, the input of the Kenyan government, the Kenyan people, the Kenyan civil society, the Kenyan communities that the US government is supposed to help is not considered in this design. So you don't consult when you're designing solutions, and you don't consult when you're taking away your benevolence. You just wake up one day. Nobody was asked, is this a good thing? Does it help? Is it helpful? So it's that whole system where we've put ourselves in a position that people can create solutions without asking us, and they can take away those solutions without asking us. So nobody asked the Africans whether this was good, whether it was helpful. Somebody sat down and in 1 month decided that a program here, which had existed for, I don't know, 40 years, is not useful. And they just scrapped it just like that. And then we find ourselves in this situation. So as I've said, it has been really a very, very strong part of the healthcare system. The amounts of money, they range in the billions of dollars. The number of people who have been benefited from these, they're in the hundreds of thousands, if not millions. And so it's tragic that this is happening. But now that it has happened, that's the question we have to ask ourselves: how did we get here, and how do we move forward? I think that's a very important question. How do we move forward?
Today's video is proudly sponsored by McKnight Clothing Brand. If you are living in Europe or in any parts of the world and you need an African clothing, you can simply check them up on their Instagram page. Their link is in the description of this video. Dr. Catherine, you are widely noted for being advocate for research justice and also for decolonizing health sector or health research. Do you care to elaborate on this, especially World Health Organization Global Podcast or Health Matter feature your talk on decolonizing health? Can you comment on this?
Yes, actually, I've been a very loud advocate for decolonizing global health. And in some ways, that's why this kind of action, the freeze of the USAID, is in a way, I feel conflicted because in some ways, what was done overnight is what we've been talking about for many years. And I feel conflicted because, again, it was done in a way that that is not consultative. It was done in a way that is so abrupt. Yes, we want to decolonize, but not on Friday. And then on Monday, we have decolonized. So, so let's talk about decolonization, what we've been talking about all this time. So, global health as a field is something which has its roots in public health. And public health has its roots in colonialism. So public health became a scientific field of study and practice as a result of colonialists tra- setting in place programs and processes to understand disease patterns and to find ways of how to prevent those disease patterns so that the colonial people who were living in these new geographies do not die. So we have very strong malaria research programs which help us. But the origins of those malaria research programs is to understand malaria so it does not kill white people who came to colonize us. And then so there's a there's a colonial history in public health. And then of course there were the wars, there were all this. And if you see even after the patterns of some of the things which are funded from like by the US government, a lot of the reason why the US government was interested in malaria is because it has American soldiers all over the world in places that have malaria. So they don't want the soldiers to die of malaria. So they invest a lot in malaria research, in malaria diagnostics, in treatment and all this. So there's a colonial history of public health. And now public health was sort of elevated from being a local practice to global public health. And that's how we ended up with this global health as a field. And the problems I've had with global health as it's currently structured, or until maybe last week, as it was currently, until last month, as it was currently structured, was that it became this field that people, mostly in the global north, the rich countries, practice. So it's like a career. You go to school, maybe you become a doctor or whatever it is, and then you say, okay, I want to do public health, and then you do a master's in public health somewhere, and then you go into global health as a career. And when you get into global health as a career, then you do things that sort of perpetuate this whole notion that stems again from the colonial roots of public health. That there are parts of the world where people have so many problems, and me, as somebody who has a public health master's from, like an Ivy League school, has solutions. So it starts from there that people get into these careers and into this system that prescribes, develops solutions that are then applied to people who have problems, but who which people are not considered to have solutions. And so we have this whole architecture of actions, of funding, of solutions, of research that is domiciled many times in the North and is practiced in the South. So we have huge programs of people sitting somewhere and defining, yeah, there's a big problem here, and these are the solutions. And then the people who are supposed to benefit from these solutions rarely have input into, first of all, defining what the problem is, and then defining what the solution is. So this is how global health has been, and we've been highly critical that at the end of the day, if it's this system that is steeped in colonialism and has been set up to sort of maintain the power disparity between the solution makers and the solution consumers, the system has been set up that way, then ultimately it solves problems, but it does not solve them in a way that is decisive and that is sustainable, so that we solve one problem and we move on to another problem. We solve the same problems over and over and over again. And then even when new problems come, we don't pay attention to those problems because they're not attractive to us. They're not aligned with our career aspirations. They're not some things we are familiar with. So we keep solving the same problems over and over again. And while this is good in the short term, over time, it becomes problematic because we keep ourselves tied up in a system where we are always dependent on others to solve our problems. The system is not set up to say, how do we help you solve your own problems? It is set up to ensure that we keep dependent and we keep beholden. These people have solutions. They have solutions, they have money. And in a way, it never allows us to have the money. It never allows us to have the problems, the solutions. And so we are stuck in this rut. And that's why one signature on a document can create mayhem on a whole continent. So that's what we've been talking about in terms of decolonized global health. And I say I'm conflicted because some of what has happened is actually what we've been advocating for. But what is problematic is that it's still in the same vein. It's like we don't ask you what your problem is. We say this is a big problem. We don't ask you what you think is the solution. We say this is the big solution. And now we say, okay, this whole problem is bad, and we take it away without even asking you whether it's actually bad or not. Maybe it's bad, but you should have asked us. And then we would have told you this is actually terrible. Take it. But you didn't ask. So that's what is problematic. And even in our aspirations for decolonizing global health, it wasn't that decolonize it overnight. We had said that we need to set in place systems and structures. And of course, that's based on the assumption that we see each other as human beings and we see each other as people that are equal, you know. And therefore, if you want to help us, then help us the right way. And so this is, in a way, it dismantles this structure that existed, but not in a way that is helpful. And it might create more problems than solutions. I don't know. But as I've said, in the medium term, in the longer term, we are all human beings. We have resilience, and perhaps we might emerge out of this different and hopefully better.
I encourage each and every one of you to please be a supporter of this channel by liking, commenting, sharing, as well as recommending individuals to us that are doing remarkable work in their various countries. We will try our best to bring them to this platform to discuss the critical roles that they are playing across the African continent. Having said that, Dr. Catherine, how do we shift from donor-led initiative to an African initiative which will improve the health system across the African continent? And how does African organizations like yours would be able to fill in the gap left behind by donor organizations, especially in the health sector across African continent?
Yes, how do we shift? Again, in the ideal world, we wouldn't have had to shift overnight. In the ideal world, this is a process which would have taken maybe 10 years. Because again, the structures that exist in our continent are not strong enough because they've been deliberately not strengthened or deliberately undermined by the system that pertained. So it's something which should have taken 10 years, but now we're here. And now that we're here, there's going to be pain, maybe for 2 or 3 years. And then all factors considered will merge out of that pain different. So this is what this is going back to the decolonization debate. So based on where we are right now, there are things which are not possible when you think about true decolonization. And true decolonization actually even takes away power from people like us because I'm trained in the West. I got my PhD from Heidelberg in Germany. And I was trained in that whole system. My worldview is shaped by the medical training that I had, which is based on a Eurocentric understanding of disease and illness and all that. So I am already somebody who is part of the system in some ways. And much as I'm here on the African continent and I lead an African institution, it's hard for me to divorce myself from the theories and from the practice and from the conceptual frameworks that guide what we do. But having said that, I'm also an African and I'm here and I'm not necessarily somebody who is far removed from the problems. I grew up here. I know what the problems are. I have some lived experience. There are things which don't make sense to me because I was born and raised in this part of the world. And there are things which, even with my training, I can say, yeah. The literature says this. This is scientific literature, but the practice perhaps is different. So I'm not the same. For instance, I'm part of the system, but I'm not the same. But having said that, I'm also not the same as, let's say, my mother, who is turning 80 and is somewhere in Western Uganda. Her worldview is not the same as mine. And her worldview is important because she deals with problems that I don't deal with. And therefore, true decolonization would require that we actually listen to the communities and ask them, what is your problem? If we are there to help, and then how can I help you solve your problem? Not, I have sat down on my computer and I've reviewed the scientific literature and I've found out that this is a problem in this part of the world. And I've done another systematic review of the literature and found out that this is the solution. And then I go look for money and then I come to solve your problem that I never asked you about. So true decolonization actually requires that we listen to the people we purport to help and they tell us what their problems are. And then we facilitate them to solve their own problems. This is something which is very long term because even my mother and the people in the community have been part of this system where you look to government to solve your problems, you look to donors to solve your problems. So it's not something which can happen overnight that you can actually just like transition from this system that has been very much top down to a system that is bottom up, where we listen to people and listen to their problems. So I think that's why I said it's something which should have taken like 10 years to reach that point. And so there are transitions that need to happen. And those transitions ideally should have been in a stepwise manner. First, as the African, I don't know, gatekeepers like myself, we decolonize ourselves, we decolonize our minds, we decolonize the relationship we have with people in the North. And then after that, we also decolonize ourselves and our relationship with communities and with government and with other people that we work with. And so this is something which is very difficult to happen overnight. But now that we're here, this has happened. So we have to see how we move forward. And I'll just say about what we've been doing as the African Population and Health Research Center. So we've been talking about decolonization for a long time. And part of the challenge has been funding flows. So people ask, um, if you look at the research, because I did the research and policy organization, if you look at the research done on the African continent and you look at the funding for that research on the African continent, only a tiny little fraction of that money comes from within the African continent. So the African government sat down and they made some commitments. This is not Abuja; it was some other commitment where they said they are going to put 2% of their GDP onto research and development. And again, like the Abuja Declaration, where government said they're going to put 15% of their of their expenditure onto health, only South Africa is close to that 2% of GDP being pushed to research and development. A lot of African countries are around 0.2, 0.5, 0.1. And it's only South Africa, which is, I think, about 0.7. They're not even at 1% of their GDP to research and development. So most of the research and development on the African continent is funded from out there, by the same people who hold the power when it comes to global health. So this is problematic in different ways. The first is that um, when we apply for funding, the funders have defined priorities. So they've said our priority is climate change and health, or our priorities is malaria. So then you have to ask yourself, okay, if I'm a researcher in malaria, then I apply for that funding. Sometimes even when you're not a researcher in malaria, you say, okay, I'll apply for that funding because I need to pursue my research career and do all these nice discoveries. So we find sometimes we are constrained by the priorities of the funders and we try to fit ourselves into those priorities. So that's one thing. But as APHRC, we define our own priorities. Then we look for the funders who have similar priorities. But again, you're sort of forcing yourself to fit into certain things. And our priorities are defined also by what is out there. So that is the problem. The other problem is that a lot of the research funding does not come directly to the African continent. It does not come directly to African researchers. It does not come directly to African institutions. So again, when I go back to the careerism in global health, there will be people sitting somewhere who are in big schools of global health. Actually, almost all the schools in global health are not in are not in Africa or Asia. The biggest global health schools are not on the African continent. That is one thing that we should ask ourselves: how is that? So there are big schools out there who uh, run global health programs and do global health research. So those people in those schools or those institutions will apply for funding to do research and discoveries around all sorts of things. And then they'll say, we want to do this research in Zambia and Chad and Kenya. And then they'll look for partners in Chad, Zambia, and Kenya. And when they look for those partners, in many instances, they don't even ask those partners, is this important? Is this what is relevant for the Ministry of Health? No. We do systematic reviews, and we know that there's a big problem in Zambia based on systematic reviews of literature that we've published. And then we tell a funder, we are going to solve this problem. And then once we have funding, we go to look for a partner in Chad to help us implement these research projects. And so the partner in Chad was not involved in conceptualization. They think maybe this is not really, really important, but of course there's funding there and they want to get some papers and all this. So they say, okay, let's do this. And so we keep doing this research that some of it is useful, some of it not so much. Some of it is relevant, some of it not so much, not so relevant. And maybe it's relevant, but it could have been relevant next year, not this year. The government may need different priorities, but the government does not have an opportunity to participate in conceptualizing research that they think is most important to them. So that's another layer. Now, the third layer is about the funding. This person based in a global health school somewhere in the north may apply for $3 million to do research in Chad, but the Chad partner receives $100,000. The 2.9 million stays, and it stays to pay salaries and to train PhD students and to do all sorts of things. And the partner in Chad gets $100,000. And the money they get is just enough, collect data, send it. It's not enough to analyze the data. It's not enough to write the papers. The $2.9 million writes so many papers, and it's the papers that people use as currency to get more grants. So the system has been set up in such a way that African scientists have been invisibilized, African institutions have been invisibilized, and they've not been given an opportunity to lead when it comes to conceptualization, but also to grow their profiles that they can lead and conceptualize science. So what we'll be doing as APHRs is to try to shift that. So first, as an institution, ourselves, we don't operate that way. We only deal with research that we have participated in conceptualizing. We deal with partners that allow us to put on the table our skills and competence, and then to define what we can contribute to a project, and then cost that. So when we engage in partnerships, we don't engage in partnerships that have been pre-conceptualized and the money has been received, and then we're being asked to partner. That's not partnering. So we don't do that. But then we've tried to pass on this message now to the other institutions that we work with. But more importantly, we launched a recent initiative which is trying to make African science visible. And there's if you're listening to this, you can Google Africa Research Connect, and then you see what you're trying to do. It's still something which is like in the beta testing, but it's a platform that showcases African scientists, African science, and African scientific institutions, so that people can know that there's a lot of talent on the African continent. And these people are potential partners. These are other Africans. If you're looking for somebody doing malaria research, you can actually go in there and look for malaria. If you're looking for somebody doing malaria research in any country, you can search based on country, based on topic, and then you find this scientist. If you're a funder looking for African scientists and you say, I don't know them, I don't know where they are, you can go to this platform and find them. Because of this sort of layering of funding, the fact that the funding is in another part of the world, and the fact that people in that part of the world have more access to the funders, they get keep. They say there's no capacity on the continent, so this work cannot happen unless we lead it. No, there's capacity on the continent. It's just been invisibilized. So we're making it visible. We're saying there are thousands of African scientists out there, highly competent, highly skilled, and therefore there's no need for these layers of going through intermediaries for Africans to do science. They can't do the science because these intermediaries, anyway, they come and they still work with the same scientists that don't have capacity. So those are the things we've been doing. And then, of course, we've been running large-scale capacity strengthening programs, training people at PhD level, training people at the post-PhD level, what we call postdoctoral fellowships, and then providing opportunities for early, Africans that are interested in a scientific career to come and work with us, to train as interns, to get fellowships. So we're building skills for individuals, but we're making the people who already have skills, we're making them visible. We're making institutions visible. And then we're doing a lot of other things because we have to shift the center of gravity and tell the world that we can provide solutions to our people as Africans. And we don't need people from other geographies who don't maybe fully understand these problems to be defining solutions for us.
Oh, thank you very much for that explanation. That was my next question because I was about to ask you about helicopter research because that's one of the things that you've always advocated against. And you've also explained various layers regarding the research or regarding the programs that your organization is undertaking, which is highly commendable. These are things that I've always been speaking about because I feel like we have the potential and the potential needs mentorship. It needs a platform where it could be nurtured. So with the kind of remarkable work your organization is doing, I think we get there, and the researchers, especially in health research, will be able to get there and do something better for the African continent. For me personally, I believe that the education system needs to shift, and we need to have a practical based education system for the young people or for the next generation coming. Because if we cannot do that, it will be very difficult for us to be able to curtail all of the challenges that you've outlined today. Because without reform in the educational system, we will continue to learn the same old things that we've learned. The curriculum continue to remain the same from 1980s, 1960s. It stay the same up to date, which does not reflect the current day reality for my generation and the generation after me. So I think that is something that the African leaders need to get involved into. Having said that, this video is proudly sponsored by Maternal clothing brand in Paris. So if you are living in Europe or in any part of the world and you need an African clothing, you can simply check them up on their Instagram page. Their link is in the description of this video. Dr. Catherine, I want us to look at some other aspect of our discussion. Recently, the Nigerian government has increased funding for health services or health sector per individual post USAID funding cut. What do you think other African countries can learn from this aspect?
I think what I'll say, the Nigerian example is very good. I think it's something which has been widely quoted. How they brought in $200 million just like that, and put it in the health sector to plug the gaps that have been left by these funding cuts. That is really commendable. The question one has to ask yourself is, where has that $200 million been? Because it's not as if the health sector was fully funded, even with the donations and the aid. It's not as if the health sector was fully funded and there was no more room to bring $200 million on the table. So this $200 million could have come earlier and complemented what the government was putting, what the donors were putting. They could have had increased the actual contribution to health much earlier. But it's good. This has happened. And whether other governments take lessons or not, they have to do something, because we can't just sit and say, yeah, this has happened and we have absolutely nothing to do, because we definitely have something to do. Many have argued that, of course, our countries are poor, no doubt about that. But our countries are also wasteful, and our countries are also um, unaccountable, and they're also not very serious when it comes to prioritization. So I think it is inevitable. Again, you ask what lessons countries are going to learn. They may learn from Nigeria, but they may craft their own lessons, because it's inevitable that the money has to come from somewhere. Now, here's the thing. There's a point that I made in some other, I think it was some interview that I was asked, and this was a point about the future of what is known as global health initiatives. Now, global health initiatives are these big funding mechanisms. Some of you may have heard about the Global Fund for Malaria, TB, and HIV. Or you may have heard about Gavi, which is like the Global Fund for vaccines. And then there's something called the Global Financing Facility, which is for the health of women and children. So these are known as global health initiatives. There are others, I think there are about six. So what these initiatives do is to collect money together, pool it. Most of the money comes from, the typical Western donors, but then of course some other countries put money. So they have these so-called replenishment rounds, where they go out and say, we need like $10 billion for the next replenishment round, and this is based on some kind of strategy. And then once the money is there, then this money is dispersed to focus on those different programs. So the Global Fund will fund programs for TB, malaria, and HIV. Gavi will fund programs in vaccines, and this includes buying vaccines at very low cost, something called pooled procurement, or it will mean maybe providing money for infrastructure for vaccines, maybe training people. So they actually put money into vaccination programs. So these programs, these global health initiatives, especially Gavi and Global Fund, have been going on for almost 20 years. And we asked ourselves, when are they going to end? Because when Global Fund was started, there was a crisis. This was in the early 2000, where there was a huge crisis about HIV. People were dying. There was all this, and so it was felt that it would be very difficult to set up the healthcare system in a way that would adequately deal with this emergency, which was the very high prevalence of HIV, the high incidence, and people dying, especially on the African continent. But now, the Global Fund has been in process for almost 20 years, and they've been doing all these things. So, are they still fit for purpose? Are they still addressing the same problem that was there 20 years ago? Why was that problem there in the first instance? Is because our healthcare systems are weak. So if they were weak then, are they stronger because of this investment in these what we call parallel programs? So, and if they are not stronger, so is the Global Fund going to be there in perpetuity? Like forever? There's always going to be Global Fund. Or are we at a point where we can say, perhaps let's start looking at the underlying health system, which created the problem 20 years ago? And if we start looking at the underlying healthcare system now, maybe 10 years from now, the Global Fund will be irrelevant in as far as supporting these parallel systems. So this is one thing and so part of the problem is these programs, the global health initiatives, have had tremendous impact in terms of dealing with this number of issues: TB, HIV, malaria. Gavi has been tremendous in terms of dealing with the vaccine issue. However, the rest of the healthcare system is still maybe slightly better than it was 20 years ago. So the rest of the healthcare system, I don't know that it is slightly better or worse, because you'd expect that after 20 years, things keep getting better. So whatever has gotten better has also been sort of undermined by this parallel structure. And I'll just give an example that these parallel structures, because they come as project-based funding, we have we have now a healthcare system that has been projectized. So it's very hard even for a ministry to conceptualize how you can do something unless it's a project. If you want to train nurses, you need somebody to come in with money to train nurses into something. We have curriculum, nurses are trained, but we don't train them in the things that are new. We don't train them in new guidelines. We want money to come as a project to upgrade skills when people are already working. When we want to, let's say, improve blood banking, we need a project to improve blood banking. The Minister of Health cannot sit down and say, we're going to strengthen our blood banking system using the resources, the money, the structures, the expertise that come from our taxes. Nope. We need a project from US government to come and strengthen our blood banking. So this projectization has actually destroyed culturally our thinking about our conceptualization of health systems. So that is part of the thing, that when you think about the future and what is possible, is to go back to looking at the health system. And I've argued that a health economist to work out the numbers. I've argued that the previous system that created disparate structures, that was reliant on development aid, was very inefficient. It was very inefficient. If you look at the amount of money that the US government claims to be giving to our countries, a huge chunk of that does not even come to our countries. It stays there in the US. So we are delivering, let's say, HIV care for 1 million people at a cost that is perhaps double what it should be if this money was coming from the Ugandan government or from the Kenyan government or from the Nigerian government. The money wouldn't be that much, because a lot of the money that we get and we put into that care, part of it does not even come to the continent. Part of it goes into propping up these huge structures that are quite inefficient. So our governments, even with $200 million, the Nigerian government might achieve what would have been achieved previously with 400 million, because now all the money is in Nigeria. It's not paying people that are based around in Washington or wherever it is. So that is one thing. But fundamentally, I think our governments need to start moving away from this projectization of health systems, the projectization of healthcare, and try to look at the underlying structures of the health system. So I wouldn't go, for now, of course, it's urgent. There's a huge crisis. I would say in the first 1 year, we need to stabilize the systems that existed, make sure they are running. And then in the next maybe 3-4 years, we need to start transitioning and take a health system perspective. Look at the whole system. Don't just look at these diseases that have been elevated in importance at the expense of other very important problems. And so, if you look at the totality of the population, if you look at Nigeria, yes, we deal with HIV very well, achieve huge impact. We deal with malaria very well, achieve huge impact. But we don't deal with diabetes. We don't deal with high blood pressure. We don't deal with cancer. So in the end, the totality, if you take the benefit from HIV, TB, malaria, and you balance it with the, I don't know, this is not the benefit, like the crisis we are creating in the area of non-communicable diseases, maybe we might find that actually on like they cancel each other out. We are making progress here. We are regressing in the other side, and at the population level, maybe we're not actually having impact at population level. So that is the problem that the lessons that we need to learn is not just put money into the same system that was very inefficient. We need to put money into strengthening the underlying infrastructure, the underlying culture, the underlying system. We need nurses, thousands of them. We need doctors. We need drugs, and not just HIV drugs. We need drugs for everybody. And we need to look at what is the most important thing for us as a country and then put money there. We may not solve all the problems, but at least let's put them in the most important problems. And we may find that actually for some countries, the problems that have been invested in are not the most important. Now, that is one part. The second part is, health has been defined at this conference that happened, was it in 1970 something? The Alma Ata Declaration that defined health not just as the absence of disease. And there was a whole sort of very nice conceptualization of what health is. That we should not look at health from the lens of disease, and we should not look at health only from the lens of the health sector as it currently exists. That health is a function of food, it's a function of water, it's a function of clean air. Right now, pollution is a huge problem. Climate is coming. It's a function of heat. It's a function of transport. It's a function of even our understanding education system. We talked about this earlier, but we've conceptualized health mostly from the health sector and mostly from a medical disease perspective. So even as we build better, as we try to come up from this crisis that we exist, we shouldn't like perpetuate the same inefficient systems, the same very narrow view of health. So that's why I said this is something which takes like 10 years. For now, we need to deal with the crisis. We need to make sure that people on care stay on care. But it shouldn't be that 10 years from now, we've maintained the same inefficient systems that actually don't create health at the population level. And I'm hopeful that our countries are going to take a different route and they're not going to start throwing money at things and at systems that have been very inefficient from the word go.
Thank you very much for that later explanation. And when you, as you were explaining along, something just came to my mind, and that is, I believe that you asked a question: where do we get the fundings from? In my opinion, where we should start from is, we should start to adjust government officials' salaries, how much they make, people in top positions, and once we start to reduce funding people in the national legislatures, ministers and directors, reduce their salaries and put that into health sector, put part of it in the educational system. I think with that we'll be able to get enough funding because there is lots of money going through reoccurring expenditure. Whatever the government gets is what it uses to salvage salaries and other take up other necessary issues or relevant to the government, not necessarily for the people. Having said that, various governments are trying to explore various source of funding. Like Ghana is currently doing maternal health program where they are partnering with private sector, and South Africa is also doing similar project in renewable energy. Do you think those initiatives are sustainable for the long term, or what do you think does that represent for our continent?
So, I mean, I think the question of whether governments are going to cut their salaries, that is debatable. It's very unlikely. It's very, very unlikely. But of course, in the short term, very unlikely. In the long term, perhaps, because once you realize actually that there's no money coming from somewhere else, and then your constituents start putting pressure about the problems that they are facing, and perhaps our governments will wake up and start doing things differently. So that's one thing. Now, the other thing is, where could the money come from? So two things. Again, I don't think we should look at money only without asking money for what. We should look both at money and then what the money is going to put into. Because if we are looking for money to put into the same system as it currently exists, then of course we can do that. But I don't think that's the right decision. And my research background and my research interest is in the area of non-communicable diseases. So no wonder this is something I'm talking about right now. So let's look at non-communicable diseases, and then I show you the distinction between putting money into the same structure and system that exists or putting money to different things. So Africa is one country that has a huge burden of non-communicable diseases. These are diseases which are not caused by agents like a bacteria or a virus. So there are things which happen in our bodies either because of our diet, because of some other exposures. They take a long time. They are not transmissible. So you cannot pass on your diabetes to another person. So that is non-communicable diseases. So they include things like diabetes, things like high blood pressure, and with time, high blood pressure leads to complications like stroke, like heart attacks, like kidney damage. So we have people with these kinds of things. And then, of course, it includes things like cancer. There are many others, but the top four are diabetes, high blood pressure, or cardiovascular disease, and then cancer, and then what is known as chronic obstructive pulmonary disease. So people having like asthma and have difficulties breathing. So those are the top four big non-communicable diseases. So let's talk about cancer. By the time somebody gets cancer, it means that the exposures that damaged their cells or damaged their system to lead to cancer, most of these exposures happened 20 years ago, 15 years ago. So when somebody is diagnosed with cancer today, the problem was exposures that happened many years back. So now we are seeing people getting diagnosed with cancers. The number is increasing. These are people who have been exposed to toxic things for many years. What are we doing about those toxic things? Nothing. But what are we doing now? We're investing in cancer treatment centers because the number of cancer cases have started becoming visible. Somebody who has kidney failure as a result of diabetes has been sick for almost 20 years. Somebody who gets a heart attack from hypertension has been sick with poorly controlled hypertension for almost 20 years. So when we set up lab catheterizations, heart catheterization labs to deal with, people's blocked vessels in the heart that serve their hearts, when we put up dialysis centers for kidney failure, this is, yes, let's do that. But if we don't do something about the pipeline of the millions of Africans that have the predisposing risk factors, if you don't deal with the hypertension, if you don't deal with the diabetes that people have that is poorly treated that leads to kidney failure, if you don't deal with the exposures to chemicals, pesticides, and all these that are creating cancer, then we are looking at, I don't even know what to call it, a tsunami of problems in the next few years. Because we've not done much to mitigate or to deal with the predisposing factors. And these factors are known. It is air, tobacco use, it is diet, the kinds of things that people eat. We used to tell people eat fruits and vegetables. Now you're eating them, but they're full of pesticides. We're not even dealing with the food system. And again, going back to what I said, that health is not just about the health sector. It's about the food we eat. So that's the thing. If you mobilize funding from the private sector or from wherever, where are we putting the money? Are we putting the money to treat cancer? Are we putting the money to strengthen the food system so people have healthy food? Are we putting the money into, I don't know, cancer treatment centers? Are we putting it in early diagnosis and early, maybe screening programs? Are we putting the money into dialysis centers? Are we putting it in treating diabetes at the primary healthcare level? So yes, we need to mobilize money, but we need to first clearly say, we are mobilizing money for what? I don't think we should be mobilizing money for the status quo, the way the system is currently set up. We should be mobilizing money to deal with things very, very far upstream. And that is in our food systems, but it's also in strengthening the primary healthcare level. So people are monitored. If you reach a certain age, you should have your blood pressure monitored regularly. You should have your blood glucose checked, see whether you're diabetic. If you reach a certain age and you're a woman, you should have your breast checked to see whether you have early breast cancer. You should have your cervix checked to see whether you have cervical cancer. We need to invest in those things far, far, far downstream, upstream, before we start mobilizing resources to invest in what is known as tertiary care. So yes, there are different ways of how we can mobilize money. It's much, much more cost effective to treat diabetes at the primary healthcare level than to provide dialysis. So even as we think about where the money is going to come from, whether the politicians will cut their money or not, I don't know. But we need to have a system that is going to benefit much more people, and that can be where we can achieve results with not a lot of money, because I don't think we have unlimited resources. Much as Nigeria can bring $200 million on the table, yeah, maybe next year when they budget, they'll add $500 million. But that's not nearly enough. When you put that into treatment centers for these chronic diseases, that can be easily wiped off without actually having a tangible impact on the population health.
Thank you very much for that explanation. You know, the African youth unemployment in Africa exceeds more than 30%. And the African Union has developed various youth development programs and policy aimed at harnessing the continent's demographic strength in research, in entrepreneurship, and in capacity building. So, and you've also talked about that in your recent program that you've launched that is undergoing review. So I want to ask you, what gave you hope for the future of African health, despite all of these challenges? What gives you hope?
What gives me hope? Oh my God, what gives me hope? Many times I'm not very hopeful. Um, Maybe because I engage with our political class by force, even when I don't want to. The political class does not give me hope at all. And what gives me hope? Of course, the youthful population is an advantage for the African continent, and there's hope in that. And I think the technological advances in the world are a huge opportunity. The question is whether we are preparing to harness those technologies. And so, yeah, and the other thing is that in spite of what politicians do, many times, being an epidemiologist, what we observe is a collection of human behavior. We don't engineer people's behavior. We don't engineer people's decisions. So people still behave in ways that is best for them. And then we observe this, and then we say, oh, this is actually what is happening after it has happened. What we see is a result of very many individual decisions. And so young people are making decisions. And in spite of what the political class tries to do, people are able to find information that could be restricted if the politicians had their way. So there's a lot of information out there. There's a lot of opportunities. I think the technological advances are a huge, huge opportunity. And having young people, I think we're a better place to harness them. If I think there's a big if. And so that's where the political class comes in. And if the political class does not get its act together, there will be a huge missed opportunity. Eventually, things stabilize. We find our way, and things perhaps become better. But we delay this. We might do things and achieve the kind of progress we want to see in 30 years that we could have achieved in 10 years if our politicians could get their act together. And I'll just give an example. Like data science right now, artificial intelligence provides huge opportunities. The future is in certain sectors. There's one person who said that there are four things. One is, of course, artificial intelligence. And then there's something they call quantum computing. I was seeing, was it Google, which were publicizing something that they've done. There's been some kind of breakthrough in that space called quantum computing. And then they talked about artificial protein synthesis. Some people have never heard of this, but I attended a meeting where people are making proteins in the lab. And these are proteins which the body does, and now they're making them in the lab. And like this could be revolutionary if they manage to like translate it into practice. So the future lies in technological advances, and the young people are the ones that are sort of attuned to these opportunities. A lot of young people use, now they use social media, they use, smart gadgets. A lot of young people are exposed to the potential for artificial intelligence. A lot of schools, even in countries like ours, are providing, computer science lessons in primary school and secondary school. So having a youthful population is a huge advantage. And the question is whether we direct this advantage to the right things. I don't think our political class gets it, and they're focusing on the things that really are not 21st century things. And so there's hope in the youthful population, but there's a big if whether our political class gets it and whether they're going to invest in the right things. So, yeah, it gives me hope. There are very many young people. They are they are energetic, they're healthy, hopefully. And there's information out there. It's much easier to get it. They're getting exposed. And so their worldview is different from our worldview. Their upbringing is different. Their values are different. And so I think if all those things come together, there is hope in that. And there's something else which, again, if I was an entrepreneur trying to invest on the African continent, the youthful population and what it will mean for the rest of the world. I don't know whether people have heard of things like demographic anxiety. It is a fact that there's huge population decline that is expected in other parts of the world as a result of, different things which have happened. And so people are not having enough babies. And we are at something called below replacement fertility. And there are projections that by, I think, 2050, Africa may make about 25% of the global population. By 2065, maybe about one third. By the end of the century, I don't know, huge numbers. And so, the number of people in the working class, Africa is going to contribute an increasingly higher proportion in the world because of its huge young population. So there are some implications around that. Because if you think about other geographies and the fact that people are going to be, people are getting older and older and older, there are some countries where in maybe 20 years' time, there will be many more older people than people below maybe 50. Those people need services, they need care, they can't work anymore. So they need people to keep the economy running. So if I was an investor, I would be investing in Africa that are going to provide care and services. Very highly skilled people who earn a lot of money and go and, they become now this source of revenue for the continent. Not people who are just desperate and they are just going. No, but it's actually intentional. And that you can actually provide care in the care economy. But you can also go and run these factories and industries that over time, there won't be enough people to run in those parts of the world. So it looks strange to be thinking about labor export. It is happening unintentionally. People are just migrating because there are no opportunities. We could systematize it. The Philippines has done it. We could systematize it and say, let's train Africans who are going to work in the auto industry in Germany in, in, in 10 years' time or 20 years' time. Or let's train nurses who are going to work to run the health sector, the health system in UK in 20 years' time. Or let's train, I don't know who. So we start training for that market because the future of the future worker in the world, 20 years from now, 30 years from now, is going to be African. And there's an opportunity to actually prepare for that future where we become the driving force that runs things across the world, that we are highly capacitated, we are competent, and we are ready to take on the world and provide the labor that the human race will need as a result of these demographic shifts. So that's something which is like sort of out there. And so again, our youthful population is an advantage, but it has to be the right things, that they have to be skilled in the right things. Right now, we're exporting people with university degrees to become security guards in the Middle East. We are exporting people with university degrees to become domestic servants in the Middle East. We could start training people to be exported, quote unquote, or who are going to live on their own because there are huge opportunities out there and who are going to serve humanity and serve the world. So yes, the youthfulness of our population gives me hope. But again, as I said, there are big ifs. I don't think our political class gets it.
We are almost to an end of this podcast. I have one more question before we take a leave of our guests. If you want to see us in better studio, if you want to see this podcast going very far, I want you to please like this YouTube channel, subscribe, share, as well as recommend individuals to us that are doing remarkable works in their various countries. We will try our best to bring them to this platform to discuss the critical roles that they are playing. Dr. Katri, I want to we are almost to an end of the podcast, and I want to ask you two political questions. That is, do you think AU Agenda 63 is achievable without it? And then my last question would be, what are some of the things that you think I would have asked and I didn't ask, and you like to share light on them? Maybe upcoming project from your organization, you could also do that, and then before we can call it a day.
I think it's good you call this podcast Unpopular Opinion. I want to apologize in advance for listening to this because my opinions are really, really unpopular. And huge apologies, people feel offended. AU Agenda 2063. The first time I learned about that, I was like, why 2063? This is so far away. We'll all be dead. Like, who cares about this? Why the certain agenda is so far off? Of course, we want to be, we need to have long-term thinking. But I think this was kicking the can down the road because there will be no one there to hold anyone accountable for this kind of this kind of agenda. So it's a bit odd that we took our agenda so far away. Why not 2030? In line with the SDG, whatever it is. I don't know. I find it very odd. The first time I learned about this, I was like, wow. I think they made like a 50-year agenda. And so, is it achievable? Maybe I'll probably be dead, so I couldn't care whether it's achievable or not. And whoever conceptualized this will be dead anyway. And there will be nobody to say, oh my God, this was a bad idea. So maybe it is achievable and maybe not. And maybe the question is, does it matter if it's not achieved? Because AU is this one thing that exists and countries, subscribe to it. They sit there in big meetings and they have all these discussions and they make all these commitments. But I think when countries go back, they still do things they want to do. And they talk about the AU agenda, but they don't really, in their own politics, they don't really subscribe to it. It would be nice to say, we see a manifesto of a presidential candidate in a country saying, yeah, Agenda 63, this is like the framework along which I've developed my manifesto. They develop their own manifestos. And then they have their own visions, 2030, 2040, I don't know, 2020 and all this. So I don't know. I don't think it will be achieved, actually, to be honest. And that's because the whole AU architecture is nice for certain things, but perhaps it's not nice for the things that AU set itself up to achieve. Because ultimately, I would imagine the AU agenda is achieved through member states. But if the member states are not mainstreaming the AU Agenda 2063 agenda, then I don't know how that's achievable. So I'm not very optimistic, really, about this.
Before we take a leave of our guests, I want you all to please be a supporter of this YouTube channel by liking, commenting, sharing, as well as recommending this podcast to your friends and family members. Today's video is proudly sponsored by McKnight Clothing Brand. If you are living in Europe or in any part of the world and you need an African clothing, you can simply check them up on their Instagram page. Their link is in the description of this video. Dr. Catherine, thank you very much for being a guest on Unpopular Opinion. And until we meet again, Assalamu alaikum wa rahmatullahi ta'ala. Thank you.
Okay, thanks for having me.